Okay, welcome everyone. Can everyone hear me? Okay, so my name is Mo. I'm a trauma fellow working here in the UK. Today we're going to talk about history, which is one of the really easy stations, in my opinion, along with the communication stations, because it's something that you do every day, really. If you're a doctor and you're asked to see a patient, you go there and you take history from the patient, and it's something that we practice every day. Some people work in countries where they don't speak English on a regular basis. It might be a bit difficult for them, but that's why we practice, and that's why practice is really important. Um, I'm not going to stress that enough because you have to practice with someone, um, whether it's a family member or one of your colleagues who's taking the exam. You have to practice, 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 especially in the history and communication stations. It's always a good idea to practice with a timer. So you ask your brother or your sister or your mom and dad or a colleague that's taking the exam, you ask them to sit down with you and you practice a few stations. You set a timer to make sure that you don't pass that 6 minute mark, especially in history, because the station is 9 minutes and you have 6 minutes to talk to the patient and then 3 minutes to discuss the case with the examiner. Okay, so you have to do your history taking in 6 minutes, and that's why practice is important, because sometimes you may find that you're running out of time. And that's why it's really important to practice with the time. Okay, again, it's really easy, straightforward. You're asked to see a patient, to take history, have a stem like any other station before you enter. And you're asked to take history from the patient. So you ask them a few simple questions. We have a scheme that we're going to talk about, which will help guide you so you won't forget anything, and you'll able to manage your time better. Okay, so today we're going to do 4 or 5 stations. In the previous course, we did it in an interactive way. So I explained the station and what we're going to ask, and then I asked one of the participants to practice the station with me. So he or she pretended to be the doctor and I pretended to be the actor. If we can do that today, that would be great. Hopefully we'll have some participants. Okay, so first I'm going to talk about our scheme. So when you go in, of course, the first thing that you do is you introduce yourself. You greet the patient and you introduce yourself. So let me see. Yeah, so number one is introduction. Okay, and you greet the patient, introduce yourself, so you say hello, good morning, good afternoon, depending what time of day it is. My name is Mo. I'm one of the surgical doctors. Could you confirm your name for me, please? And then you identify the patient. Okay. So the patient, for example, says, my name is John Doe. In that case, you can ask the patient, what would you like me to call you? And he may say, you can call me Mr. Doe, you can call me John, or whatever. And then from that point, whenever you address the patient, you call him by that name, okay? If he says that my name is John, then you can call him John from the start. But if he says his first name and his last name, then you can ask him, how would you like me to call you? What would you like me to address you, or whatever, okay? It's not really necessary, but it shows that you developing some sort of rapport with the patient. Okay, so after you introduce yourself, you greet the patient, you identify the patient's name, and then you ask him about his presenting complaint. Okay, so PC, which is the presenting complaint. And you can say that in a few ways, really. So you can say, well, Mr. John, how can I help you today? Or what brought you to the hospital? Or what seems to be the matter? Whatever you want to say. Okay, so let's say, how can I help you today? Okay, or what you to the hospital. Okay, so now we want to know what the presenting complaint is. And the patient might say something like, oh, I have knee pain, or I have back pain, or I found some blood in my stool, or whatever, okay? So that's the presenting complaint. That's why the patient is here. And now we need to elaborate on that complaint, okay? So number 3 would be elaborate. So whenever we ask a question in history, it's good to start with an open question, and then you can follow up with some closed question or some specific questions, okay? So if the patient tells you that he has knee pain, then you can ask an open question at the beginning, and you can ask him, can you tell me more about this pain? Okay, can you tell me more about this pain, or about whatever the patient is complaining from? And that's an open question, and it allows the patient to talk and give you a lot of information at once. Instead of asking 5 or 6 questions, you can ask one question, okay, just to cover everything, and the patient will give you some information, and then you can follow up with some closed questions to ask about specific things that the patient, or specific information that the patient didn't give you, okay? So can you tell me more about this pain? And in that case, the patient will tell you, oh, this pain is right here. He will show you the site, for example. It's a sharp pain, it's a dull pain. It started 3 weeks ago. The pain increases when I'm walking. I get this pain whenever I'm sitting down, or whatever. So the patient will start elaborating, okay? And in that case, you can then ask follow-up questions, what you need to know exactly, or what information is missed. Sometimes the patient won't give you any information at all. When you ask them, can you tell me more about this pain? The patient might tell you, what do you want to know? And in that case, you have to ask every question in particular, okay? So can you tell me more about this pain? This is an open question. The patient will answer, and he will give you some some information, and then you can follow up with some follow-up questions. So for pain, we have something called Socrates, okay? Just a second. Okay, and here Socrates is site, onset, character, and where the pain is radiating, associated symptoms, and exacerbating, and the score of the pain. Okay, just give me a second, guy. Sorry about that. So for pain, we ask Socrates, okay, which is the site, onset, and character, and so on. So we start with the site. So you can tell him, where is this pain? Okay, or where exactly is this pain? Okay, and the patient will tell you where the pain is. And then you ask about the onset. Okay, so this is S, and then you ask about the onset. So when did this pain start? Okay, and then you can ask also in the onset, how did it start? And then the character. Can you describe this pain for me? The patient will say, it's a dull pain, it's a sharp pain, and so on. Okay, and then you move on to R, which is radiating. Does this pain go anywhere? Okay. And then I'm not going to ask about associating. So A is associating symptoms. I'm not going to ask about it now. I'm just going to go to E and S. E, which is the exacerbating factors. So does anything increase the pain, or does anything make the pain better? So what increases the pain and what makes it better? And then S is the score. So can you score this pain for me, please? Or can you score this pain on a scale of 1 to 10, 1 being the lowest and 10 being the highest? And the patient will tell you, oh, this pain is about 4, it's a 5, it's an 8. Of course, you have to show empathy. If the patient tells you it's severe pain, it's an 8 or a 9, then you have to show some empathy. You have to say, oh, I'm so sorry to hear that. That must be very painful for you. That must be very painful for you. I'll try to give you some painkillers shortly as soon as we finish the consultation. Or you can say something like, oh, I'm so sorry to hear that. Are you comfortable to talk? And the patient will say, yes, carry on, doctor. That's fine. Okay. So yeah, that shows some empathy that will give you extra marks. Okay. So that's for pain. We ask about Socrates. If it's something else, for example, if it's an episode, like for example, the patient had a fall, then you need to divide it into 3 things. And you ask about before, during, and after the episode, okay? And we'll talk about this in a more detailed way when we get to those stations, but this is just the scheme of things just before we start. So if the patient had an episode, for example, had a seizure or a fall or so on, you need to ask 3 things. Before that episode, what happened? What was he doing before he had the seizure? Or did he have any, for example, aura, or did he feel any strange sensations before? During, we ask about what happened during the seizure. Did he, for example, did he lose consciousness? Did he black out? Did he vomit? Did he bite his tongue? Did his eyes roll up? Was he aware of what's going on? So on. And then after, for example, after the seizure, did he have any residual weakness? How soon were you able to regain consciousness, for example? Were you feeling dizzy afterwards? And so on. And that's for an episode. There are specific stations, or one specific station where we will have to do an AMTS, which is the abbreviated mental test, or we have to do an MMSE. Okay, most likely we're just going to do an AMTS, and we'll get to that station. Okay. If the patient's presenting complaint is a recurrent episode, if it's a recurrent episode, then you have to ask a few specific questions about that recurrent episode. So we have to ask about the most recent episode, and we have to ask about the first episode. We have to check for progression. We have to ask about the number of episodes and when the first episode was. And again, we'll talk about that in a bit more detail when we get to it, okay? So just to recap real quick before we move on. First, we start with an introduction and identifying the patient, okay, which is pretty simple. You greet the patient, you identify yourself, and you identify the patient. Number 2 is the presenting complaint. How can I help you today, or what brought you to the hospital? Number 3, you elaborate on that presenting complaint, okay? And here it depends on what the complaint is. If it's pain, we do Socrates. So we ask, where is the pain? When did this pain start? How did it start? Can you describe this pain for me? And does this pain go anywhere? That's if the presenting complaint is pain. If the presenting complaint is an episode like a seizure, for example, you ask about before, during, or after. If it's a recurrent episode, like, for example, he had blood in his urine a few times now, then you have to ask about a few things, like the first episode, since when, okay, how many episodes, we elaborate on the most recent one, and we elaborate on the first episode. and we check for the progression. So is it getting worse or is it getting better? Is he having more blood in his stool now? For example, he had blood in his stool about 4 or 5 times. So when was the first episode? How many times? Is it getting worse? Is it getting better? And elaborating on each episode. Okay. So after we do number 3, which is the elaboration of the presenting complaint, we move on to number 4, which is 8 questions that we're going to ask, and that includes the past medical history. So for number 4, here we have 8 important questions. And that includes the past medical history as well. And why do I say important? Because these questions will allow you to exclude your differential diagnosis, okay? So the first question that we ask is, has this happened to you before? Or you ask about previous episodes. Has this happened to you before? For example, if the patient's presenting complaint is pain, after we ask Socrates, we ask him, has this happened to you before? Have you had problems with your knee before? Have you had problems with your leg before? Have you had problems with your back before? Has this happened to you before? Have you had pain in the past in your knee? You can say it in many different ways, okay? Obviously, if it's a recurring episode, you don't ask this question. Number 2, you ask about recent health and the associated symptom. Okay, so you can say to the patient, how has your health been recently? Okay, and for example, the patient will tell you, I've been feeling tired lately, I've been losing weight, and so on. And you ask about associated symptoms, and this is very important because here you exclude your differential diagnosis. This is probably the most important question out of the 8 questions, okay? So I'm just gonna stress that here. This is the most important question. So, for example, the patient tells you he has some chest pain, okay? And you want to see other associated symptoms. So you ask him, do you have any shortness of breath, okay? Do you have pain in your shoulder? Does the pain increase when you lean forward? Does the pain increase while lying down? If the patient has back pain, for example, you can ask about neurological symptoms. Do you have problems with your bowels? Are you able to control your urine? Do you have any tingling or numbness in your toes? Do you have any weakness in your legs? And these are all the associated symptoms that will allow you to exclude your differential diagnosis. Okay? Then number 3, we ask about past medical conditions. And again, you can start with an open question. You can ask the patient, do you have any medical conditions? And the patient might say yes or no. If the patient says yes, then you elaborate. If the patient says no, you can follow up with specific questions that you want to know about. Even if the patient says no, sometimes the patient forgets. So you can ask him, do you have any medical conditions? The patient will say no. And then you can follow up with a closed question. Do you have high blood pressure? And the patient here will say, oh yes, doctor, I forgot, I do have high blood pressure. Okay. Or do you have diabetes? The patient will say, oh yes, I do have diabetes, but it's well controlled, and so on. Okay. So you start with an open question and then follow up with specific conditions that might be relevant. Okay. Number 4, you ask about medications. Do you take any regular medications? Okay. Or including over-the-counter drugs as well. So do you take any regular medication? Number 5, ask about allergies. Do you have any allergies? Number 6, you ask about previous surgeries. Have you had any surgeries in the past? Number 7, you ask about hospitalizations. Have you ever been admitted to a hospital before? And number 8, you ask about family history. Okay, and that depends on the station if you want to ask specific questions about family history. But you can ask an open question, for example, has anyone in your family ever been diagnosed with any medical condition? And the patient will say yes or no. For example, the patient might say, oh yes, my dad died of a heart attack, or my mom has cancer, my mom has breast cancer, my mom has thyroid cancer, and that might allow you, or that might enable you to narrow down your differential diagnosis. Of course, again, empathy. If the patient says that his dad died of cancer, then you have to say, I'm so sorry to hear that. Show that you're paying attention. Don't just move on to the next question. So these are the 8 important questions. Number 1, previous episodes. Number 2, recent health and associated symptoms to exclude your differential diagnosis. Again, very important. Number 3, past medical conditions. Number 4, medications. 5, allergies, previous surgery, hospitalizations, and family history. Okay? After we finish the 8 important questions, we'll move on to number 5, which is the personal history. Okay. And in personal history, you ask about smoking, you ask about alcohol, and you ask about lifestyle in general. So smoking, do you smoke? Simple question. Or have you ever smoked? Because sometimes the patient will tell you, oh, no, I don't smoke. And then you ask him, have you ever smoked? And he will say, oh, yes, but I stopped last week. So you have to just phrase it in a proper way. And that actually happens not only in the exam, but it happens in real life when you talk to a patient. I see that a lot when I'm talking to the patients in clinic, and I ask them, do you smoke? And they say no. And then I ask, have you ever smoked? And they will say, oh, yes, but I stopped last month. I've been smoking for 20 years. So essentially, he is a smoker because he stopped last month. Doesn't mean he doesn't have the risk factor. Alcohol. So you asked about alcohol consumption. Is it moderate, or how often do you drink alcohol, or do you drink alcohol? The patient will say, oh, I only drink socially. So that's okay. Don't elaborate. That's fine. Move on. If the patient says, oh, yes, but he doesn't give you any further information, then you need to know exactly how much. So you ask, how many units do you drink per week, or how much alcohol do you drink? Okay. And then lifestyle, you can ask about exercise, or you can ask about a healthy diet. Do you have a healthy diet? Do you exercise regularly, and so on? Because that might be a risk factor, for example, for heart disease. If you're doing a station where you suspect that the patient may have myocardial infarction, you might ask about lifestyles. The patient will tell you, oh, I don't exercise at all. I don't eat any healthy food because I'm always busy at work, and I always eat fish and chips. I always eat burgers. I always eat junk food. Okay, so that's a risk factor for heart disease. And you'll find that in the station. Okay. After personal history comes social. And in social, you ask about work, and you ask about living conditions. Okay. So work, simple question. You ask, what do you do for a living? Okay. So what's your job? And the patient will tell you, I'm a builder. I work in an office, whatever. Sometimes the work may be a risk factor. For example, we have a station, a bladder cancer station, and the patient works in a dye factory. Okay, so that's one of the risk factors. And you'll find that the patient is male, he's a smoker, he works in a dye factory. So you'll find all these bits and pieces which will allow you to pinpoint your diagnosis. Okay, living conditions, who do you have at home with you, or who do you live with, and so on. Okay, and that's it really for history. It's really simple. It just needs a bit of practice. This is an overall scheme which you will use in 90% of the statements. We'll go through it once more, and then we'll do some stations. We'll practice them together. Of course, there are some specific stations or some exclusions which you might need to change your scheme a bit, but this is the overall scheme. So if you go into a new station that we don't have here in our notes, which is unlikely because the stations are repeated every year, almost the same, exactly the same. But if you do get a new station, then you have this scheme that you can follow, and at least this scheme will allow you to pass if you get a new station. Okay? So, number one, read the patient, introduce yourself, identify the patient. Number two, ask about the presenting complaint. How can I help you today? Elaborate that presenting complaint, and it depends whether it's pain or whether it's an episode or a recurrent episode, and different ways of elaborating for each. And then you ask about the 8 important questions. Number one, previous episodes. Number two, recent health, and exclude your differential diagnosis through the associated symptoms. Number three, ask about past medical conditions, 4 medications, allergies, previous surgeries, hospitalization, family history. Move on to personal history, smoking, alcohol, lifestyle. Move on to social, work, and living conditions. Okay? Is it clear so far? Does anyone want me to repeat anything, or shall we move on? Is it clear? Okay. All right. So this is the scheme we have in our book. It's just printed out for you. So we can see here, that's the scheme that we've talked about, essentially the same. If it's pain, Socrates, if it's an incident, before, during, or after, if it's a recurrent symptom, we ask about these things. In confusion, we do an AMTS, and then you move on to the 8 questions. We've explained that, personal history and social history, okay? This is an example station, okay? So I'm gonna just read this real quick, and then we'll move on to the first station, which is osteoarthritis from knee pain. So the example station. Hello, my name is Dr. Mohammed. I'm one of the surgical doctors. Could you confirm your name for me, please? And the patient will say, my name is John. So John, how can I help you today? John will say something like, oh, I have back pain. Okay, so can you tell me more about this pain, please? The patient might say, oh, this pain started 5 weeks ago, and it is a really sharp pain. And then you can ask him further questions. So if he said that already, he said it started 5 weeks ago, so we don't ask when did it start. And he says it's a sharp pain, so don't ask him, can you describe this pain for me? Okay, and then you just ask the remaining ones from Socrates. So you ask about, can you tell me can you tell me where the pain is exactly? And does it go anywhere? And so on, okay? But if the patient doesn't give you any information at all, in that case, you can ask all of these questions, okay? So you have to pay attention to what the patient is saying so you don't repeat any questions, and that's really important. Otherwise, you will lose marks because it shows that you're not paying attention to what the patient is saying, okay? And then, has this happened to you before? Is this the first time, or any previous problems? That's question one. How has your health been recently? Oh, it's been fine. Oh, the patient might say, oh, I've been feeling under the weather lately. I've been losing a lot of weight, and so on. Okay, it's really straightforward. You can read it. I'm not going to read all of it, but you get an idea of how to ask the questions. Okay. Before we start the first station, does anyone have any questions? Okay, no questions? All right, perfect. So our first station is knee osteoarthritis, and the stem here is you've got a footballer who had a knee injury about 30 years ago, and he had a knee operation. He has no idea what the knee operation was or something, and he's been having worsening right knee pain, okay, which started about 4 months ago. Okay, people are asking, no, the patient is not going to be a real patient. It's going to be an actor. Okay, in history, it's always an actor. Okay, an examination, you might get an actor or you might get a real patient. Okay, but in history and communication, it's almost always an actor. All right. So knee pain, before you have 1 minute to read the stem before you enter, right? Like any other station. So you're reading the stem and it says knee pain. So before you enter, you have an idea, first of all, what it might be, what you're going to ask, and you have a differential diagnosis, a list in your head before you enter the station. You have 1 minute to read the stem and think about differential diagnosis. So I'm thinking, I'm in front of the station. I'm reading the stem. It says that this patient has knee pain. So in my mind, I'm thinking about what can it be? What can it be? It can be osteoarthritis. It can be maybe a meniscal injury, a ligament injury. It can be stiffness. It can be, for example, referred from somewhere else. And it can be an infection, so on. So when I enter the station, I already have a list and I need to exclude those from the list, right? So I've made a list in my mind before entering the station. And also when I'm speaking to the patient, I have a list with me in my head of like 5 or 6 things that it might be, and I need to exclude them, just like in real life. But here you have to think a bit fast because you have only 6 minutes. All right. So we need to exclude these things while we're asking. Okay. And right now, right here, I just added the question where we are going to exclude our differential diagnosis. So this is our differential diagnosis. Knee pain. It can be traumatic, it can be an infection, it can be inflammation, spine, or it can be, for example, something extraintestinal from an IBS. Okay, and now we're going to do our normal history taking. Okay, and I need a participant to practice with me this station. After we do our normal history, okay, right here, this is our normal history. Okay, after you do that, and you do that, and then you move on to the 8 questions. And question number 2, right here, question number 2, the associating symptoms, okay, and excluding, look here, it's really important to exclude your differential diagnosis. So after I do all of that, I will exclude my differential diagnosis in question number 2. And what I'm going to do is I'm going to ask the patient a few specific questions to exclude my differential diagnosis. So to exclude a ligamentous injury, I'm going to ask him, do you experience your knee giving away? Or do you feel that your knee gives away while walking? Okay. Do you experience locking of your knee? Do you feel that your knee locks sometimes? Do you have any fever or any high temperature? Do you have any swelling in your knee? Do you have any redness in your knee? Do you have any hotness in your knee? All right. Have you noticed any stiffness in your joints? Have you noticed any stiffness in your knee? Okay. Do you have any back pain? Do you have any weakness in your legs? Do you have any numbness in your toes? Have you noticed any rashes anywhere on your body? Have you had any diarrhea or loose stool recently? Have you had any problems with your eyes? Have you had any painful or red eyes? Have you had any back pain? We've already asked that in spine pathology. Okay, so that's how I can exclude my differential diagnosis. Okay, and in this station, most likely it's going to be osteoarthritis. Okay, so all of these will probably are going to be negative. Okay, and after you exclude everything, then what's remaining is, well, it looks like osteoarthritis, doesn't it? Because the patient doesn't have any symptoms of anything else. It doesn't seem like there's any malignancy. Okay. Does anyone want to practice this station with me? Dr. Omnia?
Hello.
Hi.
Hi.
Do you want to ask a question or do you want to
No,
practice?
I'd love to practice.
Perfect. All right. So I'm going to set a timer. I will be the patient or the actor, and you pretend to be the doctor, and we can start. Is that all right?
Yeah, sure.
Okay, perfect. All right. I'm ready when you are.
Uh,
You can have a look at this scheme here, just to guide you as to what to ask, and we can start.
do I have to follow it exactly?
No, not really. It's just a guide. Of course, this is history. You can do it whatever way you want, but this just allows you to, well, this is just a system to follow so you won't forget anything. But if you have a better system that works for you, that's absolutely fine.
Okay. All right.
Yeah,
I'm ready. Mhm.
yeah, go ahead.
Okay. Hello. I'm Amnea
Oh,
Saleh.
hi.
I'm one of the exam candidates for the day. May I please confirm your name and age?
Oh, my name is John and I'm 50 years old.
Nice to meet you, Mr. John.
As
Can
well.
you tell me what seems to be the problem for the day?
Well, I have this knee pain that's been troubling me for quite a while now.
I'm so sorry to hear that. Is it both your knees or it's just one side?
No, it's just my right knee right here.
Um, has this been something that's been going on for a while, or
Yeah,
has it?
it started about 3 months ago. I wasn't doing anything really, but it started about 3 months ago and it's been getting worse since.
I'm so sorry. Would you like me to prescribe you some painkillers at the moment before we continue this
No,
consultation?
I'm fine. I'm fine. You can continue, doctor. Thank you.
You're welcome. Well, okay, then my next question would be, if this pain does it come and go, or is it just something continuously happening all the time?
No, it's always there.
It's always there. Does it have bouts where it's aggravated or increased in intensity, and then there are bouts where it's
Yeah,
decreased?
yeah, sometimes when I'm walking for long periods of standing, the pain increases.
Okay. Is there anything that you do to help relieve you of that pain?
Not
Uh,
really, just
No,
rest sometimes helps. And painkillers like paracetamol.
I'm so sorry to hear that. I'll just have you noticed any change in the shape of your knee?
No, not really.
Does while you walk, have you experienced that your knee gives away?
No,
Does it lock?
no, it doesn't.
How about any numbness down your leg or your
No,
thigh,
I don't have any numbness now.
and no stiffness?
Um, I I do feel that it's stiff sometimes, but nothing severe really.
Well, the stiffness, is it only in your knee, or have you felt it in any
Just
other like
just my
joint?
knee.
Just your knee.
Yeah.
Have you had any rashes?
No rashes, no.
Any GI upset like diarrhea? Have you
What do you mean
do you
by
go to
GI upset?
do you go to the bathroom more than you're used to? You
No,
feel
my
like you have to
bowels have
puke?
been fine. My
Okay.
bowels have been fine.
Do you have any back pain, increased intensity back pain?
No, my back has been fine as well. It's just
All
my
right.
knee, really.
Oh, okay. Um, do you have any other medical conditions that I should be aware of?
No, I don't. I'm fit and well.
No high blood pressure or
No,
diabetes, God forbid. Do you have any allergies?
no, I don't.
Okay. Are you on any medications?
I just take paracetamol and sometimes codeine just for my knee, but nothing else.
So just for the pain, but you're not on any other
Just,
medication.
just for the pain, yeah.
Okay. Does anyone in your family have this or have
No,
had a similar problem?
no one in my family has any medical conditions.
Okay. And what like and they've never had any knee problems either?
No, they haven't, as far as I
Okay.
know.
All right. I'll just ask you some social questions. If you can tell me, what do you do for a living, Mr. John?
I work in an office. It's a desk job, really, an accountant.
Okay. So, you don't have to walk long distances,
No,
right?
I'm mainly sitting on my desk most of the
Oh,
day.
okay. How about at home? Do you um, do you have help around the house, or do you have to do most of the
Well,
work?
I'm independent, but I do live with my partner. But I don't need any help really.
Okay. Are you a smoker?
No,
Have you ever smoked before?
no, I've never smoked in my life.
How about drinking?
I just drink socially.
Okay. Um, and do you have any? I know that you're here because of your knee, but do you have any concerns about what like this is really worrying you because of just the pain, or do you feel like that there's something else?
No, well, it's just the pain that's troubling me, and I want to know what's going on, really. But I don't have any specific concerns apart from it's getting really painful.
Okay. I hopefully we will get that sorted out soon enough, and I'm sure my consultant will have something to say about it and help you with that. Um, can I just ask you a quick review about your other problems? You told me that you don't have any other medical issues or other medical conditions that you've done in the past. No past surgeries, right?
I did have a surgery on my knee actually about 20 years ago, while I was playing football. I had this ligament, I think, called meniscal injury, and I had surgery to have that fixed. That was a long time ago.
So that was the one surgery you did. You didn't do any other surgeries.
No.
Okay. Um, since that surgery, have you had trouble in your knee other than the past 3 months when you started experiencing pain again?
No, it's been fine after the surgery, really. I wasn't able to play football again, but my knee has been fine since.
Did you stop football at the time of the meniscal injury and you
Y-
haven't played football ever since that
Yeah.
time, or did you go back to playing football in between?
Mm, no, I haven't. I haven't played football since.
Do you feel any muscle pain or other joint pain other than the knee?
No, no, really.
Any muscle pain or cramping that happens in your legs?
Nope.
Have you had any unintentional weight loss in the past couple of
No,
months?
no,
Okay. Is there anything that you think I might have missed that you would like to tell me so
no,
I
not
can?
really.
All right. Well, I think I have everything I need. I will inform my consultant about your case and I will get back to you as soon as possible and we'll figure this out.
Okay, perfect.
Thank
All right.
Thank you.
So first thing, you've done really well. You've got really good communication skills. And you'll probably pass easily in history and communication. But just
Thank you.
just a couple of things. First of all, it's 7 minutes and 30 seconds. Okay.
Okay.
Um, in the
I
exam, you'll
kept going.
probably have about, yeah, I know you don't have a timer and the examiner didn't stop you, but most likely in the exam, the examiner will stop you. and you will hear a bell as well going on. Okay, but just to give you an idea about time management. Um,
Okay.
in terms of well, you've followed your own scheme, but it's really similar to what we've explained about. That's why I say the 8 questions, because you almost forgot about the surgery right here, okay, which is question number 7, and hospitalizations. So if you're following the questions in order, you will know that after allergies comes hospitalizations and surgeries, and then family history. Okay, it just gives you, well, allows you not to miss anything.
Mm-hmm.
Apart from that, you've done really well. I don't really prefer doing a system review in the end. I know Dr. Salah likes it, but I don't think there's enough time to do a system review in the end. And that's why I have question number 2 here, where you exclude your differential diagnosis and ask about any associating symptoms that you might think is relevant. Okay, so in question number 2, we ask about recent health, and of course you exclude cancer and you exclude other problems, and you can ask about specific questions or specific systems that you're concerned about, instead of doing a whole system review in the end, which takes a lot of your time. But again, if you think that you might squeeze it in, or you're able to squeeze it in, then that's fine, that's up to you. Okay.
Okay.
Socratic, we've done. Yeah, that's been. Have you had problems with your knee before? You've said that. Question number 3, medical conditions you've asked, and you've asked also close question. You've asked about regular medication, that's fine. You've asked about allergies, smoking, alcohol, and living conditions and work. So you've asked about everything really. Okay.
Okay.
Oh yeah, and question number 2. Don't forget to ask about trauma as well, okay, while you're excluding your differential diagnosis, okay. You might have asked, I forgot, sorry, if you did, then forgive me. But while you're excluding your differential diagnosis, don't forget to ask, have you injured yourself, or have you banged your knee on anything, or have you had a fall recently, or so on, okay.
All right.
So I'm going to start the discussion. Would you like to do the discussion?
Yeah, sure.
Okay. So this is important, really. Your presentation, after you do your history, after the 6 minutes, you're asked to speak to the examiner. So your presentation is really important, because you have like a mark or 2 on the presentation. And these are really easy marks, because we already know the stations before we go in, we practice them. And you can practice your presentation really well before going for the exam. So you can basically make sure that you have these points in hand before going in, okay? So I'm the examiner. Can you present your case to me, please?
Um, Mr. John, I can't remember how old you said you were. And
50.
you presented with okay, you presented with right knee pain that has been uh, increasing in frequency and intensity over the past 3 months. The only thing that relieves the pain was paracetamol. You're also experiencing stiffness, as well as he had a previous meniscal tear 20 years ago on that same knee. He has an office job and his mobility is not affected, but the pain has been affecting his daily routine. My main differential would probably be traumatic osteoarthritis.
Okay, good. What other differential diagnosis would you like to exclude?
I'd like to exclude meniscal injury and rheumatoid arthritis, as well as any other spine pathology like a lumbar disc or.
Okay, perfect. Did you ask about the character of the pain? I don't know if you did. You might have. But if it's one
I
of the,
I asked
the
when I was talking to the patient, I asked if the pain was increasing in intensity or decreasing, if it felt like it was there all the time.
is it
So,
a
and then
dull or
I
sharp or
had
so on? Okay. What investigations will you do for this patient?
I would like him to do a standing knee X-ray AP and lateral
Okay.
view.
Okay. And you said it's most likely osteoarthritis. So how would you treat osteoarthritis?
I probably do if it is bearable, I do conservative management, in which I would try, if the patient is overweight or obese, I would have them achieve a healthy weight, um, regular exercise, with after obviously being after giving them a good analgesia to be
Mm-hmm.
to help relieve the pain, have good physiotherapy, offer heat application to the knee, to give them relief.
Okay.
If that doesn't work, then we would go down the surgical route, which would include um, um, our partial or knee replacement,
Yeah.
total
Yeah.
or partial
So
knee replacement.
yeah. So yeah, of course, you start with conservative management, and if it doesn't work, then we'll think about other interventional options or surgery. And the main thing here, obviously, is knee replacement. That's the aim. If the patient has deformity, which is causing his osteoarthritis, then you can think about doing deformity correction by doing a realignment osteotomy. Um, but if the patient doesn't have any deformity that's causing his problems, then an osteotomy will be useless and we'll have to do a knee replacement. Okay.
Okay.
And what causes of failure of knee replacement? So in any, I would say, failure prosthesis, you can divide it into three, as in patient factors, um, and then surgeon factors, and the prosthesis, and then you can add stuff under each one if you want, but that's kind of FRCS level. For here, we're going to talk about just simple stuff. You can say infection, wear and tear, or a fracture, or a septic loosening, and that should be enough for this exam. Okay. um, will the patient, if I think they're asking if the patient has a knee replacement, will he be able to play football in 9 months? And most likely it's going to be no, the patient won't be able to play football if he has a knee replacement.
Okay.
Okay, perfect. Thank you very much.
Thank you.
Well
I have
done.
one. Thank you. I just have one comment. I don't have the notes that you're reading from.
Oh,
Is
you're
it
not,
just me, or is it
is it not
everyone
on the
else?
drive?
No,
It's not on the
not
Google
this
Drive.
version. Not this
Oh, okay.
version. A different version.
That's fine. I can upload it after the lecture. If someone can
Okay.
remind me on Telegram.
Okay.
Yeah.
Thank you.
All right. Cheers.
Thanks.
Um, Next station is back pain. Well, before we move on to the next station, is it clear so far? Does anyone have any questions? Someone says, could you please update the history file? Yeah, that's fine. I'll do that. Anything else? No, no. Okay. So back pain, there are two stems. One of them is a functional back pain or mechanical back pain, and the other one is the cauda-equina syndrome or cauda-equina compression. Of course, one of them is an emergency, which is the cauda-equina, and the other is just simple back pain. Okay. Again, we're going to do a normal history taking scheme like Dr. Omnia just did. Um, we're going to repeat everything again. I'm going to practice it with someone, if someone is willing to do so. You introduce, you ask about the presenting complaint, you elaborate, you ask about the past medical history and the 8 questions and so on. But in question number 2, again, we need to exclude some stuff. If the patient has back pain, then we need to exclude neurological symptoms. So we have to ask specifically about weakness and numbness and tingling and so on. Okay, if it's cauda-equina, then we have to ask about problems with the bowels or the problems with the urine, okay, or the waterworks, which is the layman's terms for urinary tract. Okay, that's really important. always exclude cancer in question number 2. So you ask about constitutional symptoms. Have you noticed that you've been losing weight recently? Have you lost any weight? Has someone told you that you've been losing weight, and so on? Do you feel that your trousers are getting looser, or so on? You can ask it in many different ways. Stiffness, of course, exclude that for spondylitis or ankylosing spondylitis. So in question number 2, you ask, do you have any stiffness? Do you have any morning stiffness? Do you have any back stiffness? Infection for TB, so you ask about fever, sweating, feeling unwell, and so on. And other spinal causes, non-spinal causes, sorry, of back pain, for example, renal calculi. So you can ask about burning sensation while passing urine, or difficulty in passing urine, or loin pain that might be referred to the back, or so on. Okay. Who's willing to do this station with me? Someone raise their hand, please. Come on, people. Yeah, there is someone, yes. Dr. Anuj?
Hello, yes.
Hi.
Hi, how are you?
Yeah, not too bad. Would you like to start? Is everything clear so far?
Yes.
Yeah, perfect. Okay. So yeah, let's start. I'm ready when you are. I'm going to set a timer, and I'm going to let you know once we hit the 6-minute mark, so you don't just carry on. Okay?
Okay.
Okay. Yeah. Go.
Hello, I'm Dr. Arnold, one of the exam candidates for today. Could you confirm your name and age, please?
Hi, I'm John, and I'm 50 years old.
Nice
Again.
to meet you. Nice to meet you, John. How can I help you today?
Oh, I've been having this back pain, doctor.
Uh-huh. I'm really sorry to hear that. Before we start, uh, could you please tell me on the scale of 0 to 10, how do you rate your pain?
Oh, I would say it's about a 6 or a 7.
Uh, it must be really it must be really hard for you. Do you need any analysis before we start?
No, I'm fine at the moment.
Okay. So, can you tell me where exactly is your pain?
Oh, it's right here in the lower back.
Okay. And how did the pain start?
Well, it just started by itself, really. It's been going on for about 2 or 3 days now. I
Mhm,
wasn't doing anything in particular. It just started.
mhm. So, can you describe the character of the pain, please?
I would say it's kind of a sharp pain, really. It's hard to describe, but it's kind of
Mhm.
like a sharp type of pain.
Okay. So, does the pain move to other places?
Um, Well, it's kind of hard to say, but I feel like it's traveling down both of my legs.
Okay. So, do you have this pain on any specific day or night? Is
No,
it
it's there all the time, really.
okay? So, is there anything that makes the pain feel better, or it worsens
Um,
the pain?
when I lean forward, I think it helps a bit, but not much, really.
Uh, ok- uh, okay, so has this happened to you before?
Um, uh, this is the first time.
Okay, so how do you feel recently?
I've been feeling well, apart from this pain, really. I was absolutely fine last week.
Mhm. Do you have any medical conditions?
No, I don't have any medical conditions.
Have you had any numbness down your legs or buttocks?
Yeah, I do feel like my both of my legs are weak, and I feel like there are pins and needles in both of my feet as well.
Okay, so have you ever had? So how about your bowel and water works?
Oh, well, it's good that you asked that, because today I couldn't control my bowels, and I
Okay,
think I might have soiled my pants.
okay.
But this is the first time this has happened to me.
I'm going to ask you a personal question if it doesn't. if you don't mind, please.
Yeah, of course.
So, do you have any problem or difficulty in gaining erections?
I have to say, doctor, I haven't tried recently. It's been just very painful that I haven't tried.
Okay. So, did you have any history of trauma or incident prior to the pain?
No, no, I haven't injured myself at all, no.
Okay. So, did you experience any stiffness over your back?
No stiffness, just the pain
Okay. Do you
and
have
the
any?
weakness in my legs.
Okay. Do you have fever?
No, no fever.
So, cough or any neck swelling?
No, nothing of that.
Did you experience any unintentional weight loss for the last month?
No,
Any loss of appetite?
no,
Okay. Do you have any tummy pain or any diarrhea?
no,
Have you noticed any rashes anywhere in your body?
no.
Mm, do, do you take any regular medications?
Just the painkillers for my back, but they're
Okay.
not helping.
Do you have any allergies?
I'm allergic to penicillin.
Okay. And do you have any history of any previous surgery?
I had surgery on my back 20 or 15 years ago for a disc in my back.
So, now what about your family history? Does anybody have similar problems or any medical conditions?
No, they're all fine.
Okay. Now I'm going to ask you about, do you smoke or drink alcohol?
No, I don't smoke and I only drink socially.
Okay. What about your physical activity?
Well, I'm normally fit and well. I try to exercise as much as I can, but
Mhm.
obviously for the past 2 days, I haven't been able to do any of that.
What do you do for a living?
I'm a postman.
Where do you live?
I live about 10 minutes ago in a house with my partner.
Okay. So I think I've got all. Do you want to add anything if I missed from your history?
No, we've been really good, doctor. Thank you. I just want to know what's going on.
Okay. So I've got all the things I wanted. I talked to my consultant and come back with you,
Okay,
and we'll figure
thank
it
you.
out. Thank you.
Thank you.
Thank you.
So, really good, Dr. Anuj. It's just about 6 minutes. It's actually 5 minutes and 58 seconds. So you're spot on. Your timing is perfect. And I think you've covered almost everything. You've gone through Socrates. You've asked about the character, where the pain is, when did it start, it helps, what increases the pain, what makes it better. And you asked about the score. You started with the score, but that doesn't matter. You asked about previous problems, you asked about recent health, you excluded cancer, you asked about trauma, and here you excluded all your differential diagnoses, you asked about infection, TB, and so on. Okay. Were you diagnosed with any medical conditions? You've asked about that, you've asked about previous surgery. I don't think you forgot anything. Someone in the chat wrote ice. So ice, you can or can't do it. Dr. Salah will tell you that you have to do it. Personally, in my exam, I didn't. It's up to you. I think if you have time, you can ask about it. So ICE is ideas, concerns, and expectations, what the patient thinks it is really, or what the patient is concerned about, uh, and what the patient expects us to do for him. Why is he here? So again, you can cover that during your consultation in a way, or you can ask it at the end. But in my exam, personally, I didn't ask it. And in one of the history stations, I'm pretty sure I got a full mark because the examiner told me that you're the only person today that got a full mark in this station. And I didn't say ice. So I don't think it's really mandatory, but if you can say it, then do say it. That's fine. If you have a bit of time, then yeah, of course you can do ice. Okay, and I've added it here to the end. After you finish your history, you can do the ice. Okay. So Dr. Anuj, I think really good. Let's discuss the station. Can you present your case to me, please? Can you hear me? Can people hear me? Okay. I think we've lost Dr. Anu. Okay. Power cut. Okay. So again, presenting the case, that's fine. Let me just do an example presentation. Today, I saw Mr. John, who's a 50-year-old gentleman who came in with back pain. He's been having back pain for the past couple of days now. It's been getting worse. He also has lower leg weakness in both of his legs. He's got tingling and numbness in both of his feet. There is no history of trauma. He's not been feeling unwell or anything. There's no recent weight loss. There are not any signs to suggest that he has infection. Okay. My main sorry, and then you can say about the work. He works as a postman. He had surgery on his back about 20 years ago for a herniated disc, but otherwise he's been well until the past couple of days. He also had one episode of loose stool this morning, so my main differential diagnosis would be caudal equina because of the bilateral symptoms and because of the history of loose stool. Okay, so what I said just now is just an example presentation, which I just made up literally right now. Of course, you can say it in your own way, but obviously it's better to practice it beforehand before you go to the exam. It's better to practice this, okay? Because these are a couple of points that you don't want to lose. And if you know that, how many stations do we have? We have like 15 stations or something. So you can just memorize the presentation for each of them. And in your exam, you can just say it and you will get those extra couple of points, okay? In terms of discussion, of course, it depends what the case is. So it might be mechanical back pain, or it might be caudal equina, like we said here. So it can be mechanical back pain, or it can be a caudal equina. Here in this case, in my history, it looks like it's caudal equina, okay, because there are neurological symptoms and there is disturbance of bowel habits, okay, with no history of trauma and previous history of lumbar surgery or back surgery. Okay, so here I would say my main differential diagnosis would be caudal equina syndrome, okay, because of this, and that. Or if it's mechanical back pain, then I would say my main differential diagnosis is just simple or mechanical lower back pain because there is a history of heavy lifting. The patient, for example, works in a factory, he lifts heavy stuff. He had previous episodes over the past years. There's no systemic illness, no neurological symptoms, and so on. Okay. So what is caudal equina syndrome? The examiner might ask you. So you will say caudal equina syndrome is a rare but severe type of spinal canal stenosis causing compression on the caudal equina roots. And this is you have to say it's a surgical emergency. Okay. And symptoms may include bladder or bowel dysfunction, okay? So that might be incontinence or it might be retention. And actually, if you read papers on caudal equina, urine retention is more common than urinary incontinence. And that's why we usually do a bladder scan. So I was doing a spinal job last year, and when a patient presents with a query caudal equina syndrome, we would do a bladder scan, which is an ultrasound scan, which the nurses actually do in ED. So you do a bladder scan, you check how many milliliters of urine in his bladder, and then you ask the patient to go to the loo, and then you do another bladder scan to see the residual volume. Okay, to see if there is any urinary retention or not. And that's something real quick that you can do in ED, and there's a bladder scan machine, which the nurses know how to use, and they just check how many mils of urine in his bladder. They ask the patient to go to the loo, empty his bladder, then come back and do another bladder scan to see if there's any urinary retention or not, okay? Bilateral sciatica, okay, it's usually bilateral symptoms because it's central. If it's a disc, it's usually to one side, right or left. But again, caudal equina syndrome can be one-sided, but I would say most of the time it will be bilateral, or especially for the sake of the exam, okay? Numbness in the saddle area, okay? So disturbance of S1, S2, S3 roots, and that's why whenever a patient comes in with a query caudal equina syndrome, what we do is we do a perianal sensation, and you have to actually do a digital rectal examination as well to check for the anal tone, and you ask the patient to squeeze, you check for the anal squeeze as well, okay? Investigations. So of course, for caudal equina or spinal case, you have to do full examination. You have to check all the dermatomes, all the myotomes, and all the reflexes of the lower limb. So you do a full examination, okay? You look for perianal sensory loss and anal tone, like we said. Okay, check for reduction of power and reflexes. So dermatomes, myotomes, and reflexes. And what we usually do is we just look at the Asia chart. And if you don't know what that is, you have to look it up. It's really important. So Asia chart is just a chart with all the dermatomes, myotomes, and reflexes. And you just mark on that chart and you write the power 4 out of 5, 3 out of 5, and you just file it in the patient's notes. It's really simple and easy. And that way, when you're doing a repeat examination, for example, the next day, or you're doing a repeat examination in a couple of hours, you're able to find out if the patient has improved or he's deteriorating or so on. And that's why we do it on the Asia chart. So we have a consistent way of just finding out, okay? And it also tells you where all the dermatomes and myotomes are. So it's easy. Bloods, of course, full blood count, checking the white cell count, check for infection, CRP, and erythrocyte sedimentation rate. A simple X-ray to check if there is anything obvious. Sometimes you might find a slip or spondylolisthesis or a fracture or osteoarthritis or so on the X-ray. But the main thing, of course, is an urgent MRI scan. But before you do the MRI scan, you have to do an X-ray. No one will agree to do an MRI scan without an X-ray. You can get an X-ray in 5 minutes. Just send the patient around to X-ray. He'll be back in 5 minutes, and you have an idea of what's going on. If there is decreased joint space, decreased disc space, there's any fracture, any spondylolisthesis, and so on. And most of the time, the X-ray will probably be normal, or it will show just a decreased disc space. Okay, and in that case, you have to request an urgent MRI scan so you can have a look at the spinal cord and you can have a look at the caudal equina. Okay, consider DEXA, consider chest X-ray, OTB. I would say those are the most important things. And then management, if it's a simple back pain, then you'll start with conservative management, of course, and physio, analgesia, and so on. If the patient has red flag symptoms or if he has caudal equina, then he will need urgent surgery. And in caudal equina, what we do is we do decompression, okay, which is most likely going to be a laminectomy, just to increase the space, really, because the space is now tight because of a disc herniation or so on, and doing a laminectomy allows the caudal equina to breathe. It gives them more space, and sometimes surgeons will also add some removal of some disc material, okay, like a discectomy. Okay, so you do both. Okay, you remove the lamina from the back and you remove the discs from the front. Okay, and that allows the caudal to breathe. Yeah, we've said that, and social worker if the patient has any problems, social issues. Is it clear so far? No, not clear. As no one's replying. Okay. Wow. Okay. Guys, shall I move on? Is it clear? Any questions? Can someone answer me, please? Okay, thank you. I feel like I'm just speaking to myself. Okay, lower limb claudication. This is our third station. Again, normal history taking. Please, if you have any questions, let me know, okay? So I just don't know that. Well, don't want to be speaking to myself. Again, we're going to start with normal history taking, okay, in the lower limb claudication station. And here we have to exclude a few things. So lower limb claudication can be due to a spinal problem or it can be due to a vascular problem, okay? And in red here, I added where we're going to ask each question. So here in exacerbating factors, we're going to ask if the pain increases in cold weather or not. So that's a sign of vascular problems. Does the pain increase while going uphill? Or does it decrease while going uphill? So you kind of differentiate between a vascular claudication and a neuroclaudication, okay? We also ask about associated symptoms. We ask about calf pain, calf swelling, calf redness, shortness of breath to exclude DVT and PE, okay? A history of trauma, again in question number 2, and also in question number 2, we ask about constitutional symptoms such as weight loss and so on. Okay, but apart from that, it is our normal scheme. All we are going to do is exclude our differential diagnoses, which you already have an idea what they are before entering the station because you have a stem before you go in. Who wants to practice this station with me? Hands up, please. Who wants to practice this? If no one raises their hand, I'm just going to pick someone at random. Dr. Rajib, would you like to do this station with me? Hello? No participants. Okay. Just give it a couple of do this thing for some reason. Okay. So you'll do this one and Dr. Anuj will probably do the next one unless we have other participants.
Okay.
I'm ready to start when you are. Just normal history taking. I have some lower limb claudication, which is most likely going to be vascular. But yeah, you can start whenever you want.
Okay, I'll just get my notes ready.
Yeah, sure. Oh yeah, so in the exam, you will have a piece of paper and a pen if you want to take notes during history. I personally didn't take any notes. I think you can if you want, but I don't think it's really that important. You can usually memorize the answers. If you pay attention, you will know what the patient is saying. And I think, in my opinion, it will give you extra marks to show the examiner that you remember everything without writing it down. You're paying attention instead of just writing everything. because also when you're writing down, you're not maintaining eye contact with the patient, which is really important in history and communication, to maintain eye contact and to show the patient that you're listening. And if you're writing everything down, I don't think it will look that good. You can write a couple of stuff, but try to maintain eye contact as much as possible. Okay.
Okay. Hello. I'm
Hi.
Hi, I'm Amneya Salah. I'm one of the exam candidates for the day. May I please confirm your name and age?
Oh, my name is John, and I'm 65 years old.
Nice to meet you, Mr. John. So what seems to be the problem for today?
I've been having this pain in my legs for a couple of weeks now.
I'm so sorry to hear that. Is it both legs or is it just one leg?
Yeah, both legs, yes.
Can you tell me when this pain started?
Well, yeah, I told you it's been going on for a couple of weeks now, and I think it's getting worse. I'm not sure.
Um, d does anything aggravate this pain or decrease or reduce
Yeah,
it?
I think the pain gets worse in cold weather. When it's cold outside, I think it gets worse. And when I'm walking for long periods, I feel the pain gets worse as well.
Okay, so when you rest and let's say keep yourself warm, then the pain is reduced. How about painkillers? Does that help?
No, painkillers don't help really.
If we were to talk about this pain, can you describe this pain a bit more?
It's like a shooting pain. It's like a pulsating pain down my leg.
On a scale of 1 to 10, 1 being it's really low and 10 being the worst pain you've ever had, what number would you give it?
I would say it's about a 6.
Oh, that's very unfortunate. I'm really sorry to hear that. So you've said you've had this pain for a couple of weeks, and it is when you rest, it decreases. Does it totally disappear, or is it just like a little less intensity, but it's always
Yeah, I
there?
think it's it's a little less. It's much less actually when I'm resting, but it's
But
still there.
it doesn't go away totally,
No, it
right?
doesn't. No, no.
Um, so when you say when you walk, like, is there a specific distance that you can walk before you actually start experiencing the pain?
I would say maybe a couple hundred meters, maybe 200,
Okay.
300 meters.
Have you noticed that this distance is actually decreasing over the past couple weeks? So in the beginning
No,
it wasn't that
it's
bad and now it's
just,
worse.
well, because the pain is getting worse, I feel that I'm not able to walk as much, but yeah, maybe.
Okay. Um, Hopefully we'll come up with a solution for this. Can you tell me, do you feel any cramps in your leg?
Yes, I do, along with the pain, yeah.
Okay. How about if you say it hurts when you walk, but what if you're going up a hill? Does that usually
Yeah, it's the
increase?
same.
It's
It's
the
the same,
same.
doctor. It's still painful.
Do you feel any numbness or tingling?
No, not really.
All right. Have you had any have you noticed any skin changes or wounds over your leg?
Yeah, my feet are almost blue now, I think, and my skin is a bit dry as well and cold.
But you've never had any discontinuation of the skin or actual
No,
wounds.
no,
Okay. Have you had any problems when going to the bathroom, whether peeing or
no,
pooing?
no,
Uh, have have you had any swelling in your calf or calf pain?
no, no,
And no changes of redness, only blue in color, right?
no, no changes and no calf heaviness, no.
Okay. How about your breathing? Have you had any breathing problems lately or chest pain?
No, my chest has been fine.
And you've never banged your leg or hit your leg previous to the pain that you started experiencing these last
No,
couple of weeks?
no, I
Okay.
haven't.
Have you had any medical issues in the past or
No,
surgeries? No
no, I
surgeries
haven't.
either?
No,
What about allergies?
I don't have any allergies.
Have you been taking any medications?
No, I haven't.
Um, what about a family member? Have they had any similar conditions to what you're experiencing right now?
No.
No. Can I ask you, are you a smoker, Mr. John?
Oh, yes, I do. I smoke a pack a day. I've been smoking for the past 20 years.
Okay. Have you had, do you drink?
Yeah, I drink, I would say, a couple of pints per day.
Okay. Again, I'll ask you, I just want to, I know this may be a bit personal, but what about your living condition at home? Do you move about freely or do you have help?
Yeah, in the house, I'm fine. I do have my wife with me, but I'm fine.
Okay, that's good to hear. Um, can um, can you tell me what do you do for a living?
Oh, I'm retired now, doctor. I used to be a teacher.
Uh, okay, well, do you have a routine that you follow, even though you're
No,
retired, that you would go out
no.
on specific days?
Well, I've been trying to have regular walks, but that's not happening because of the pain. So you're now 6 minutes and 20 seconds, and I think you're
Okay.
almost done. Yeah.
Yeah,
So you've asked, yeah.
I was supposed to be asking about the system review if you've had any like weight losses and stuff.
Okay. Yeah, it's fine. Like I said, if you have time, you can ask about the system review, but I'd rather you would ask it here in question number 2, with recent health. So if you ask about recent health, how has your health been recently? Oh, I've been fine. Any weight loss? No. Have you been feeling unwell? No. Then you can move on. You've done that already.
Okay.
And then you can exclude other things like you've done. Um, does the pain increase while going uphill? Sorry, we've asked that, and it's a submitting factor. Sorry, do you have any back pain? Do you have any tingling and numbness? Do you have any calf swelling, calf pain, calf redness? Any history of trauma? Did you bang your leg or anything? And I think you've covered everything. Let's see. Yeah, you've done that. Do you think you've missed anything? I don't think you've missed anything or missed much.
I don't
Mm,
know. I haven't. It's just the like in my scheme of things, I've only missed the ice and the system review. So the
okay,
malignancy and the number 2 question that I'm
okay.
supposed to put in number 2.
Yeah, that's fine. But you didn't have time for it.
Hmm.
So you were going to ask them, but it's now 6 minutes and 30 seconds. So you're already 30 seconds. Um, well, you've taken an extra
Overtime.
30 seconds. Yeah. Um, it's perfect, almost. You just need more practice on time management. Um, but other than that, I don't think you'll have any problems in your exam. It's just
Thank you.
time management. That's why I'm asking people to practice with me, because it's all about practicing, practicing, practicing. Everyone can take history, but not everyone can do it in 6 minutes, and that's the problem, I think. Because you can spend 20 minutes with the patient and ask everything, but we need to have a structured approach in order to finish it in 6 minutes. So for this station, I told you I'm 65. I have skin changes. I have a pulsating or shooting pain in both of my legs, which increases in cold weather. I'm not able to walk for long periods. Um, and there is no history of trauma. There is no neurological symptoms. So it's most likely, and I'm a smoker as well, right?
Yes.
So it's
Pack
most
a day.
likely, yeah, it's most likely vascular claudication from the history, don't you think?
Yes.
And in the exam, it probably it's going to be more clear than that. Um, so can you present your case?
Okay. Uh, I took a history from Mr. John. He's male patient, 65 years old, that presented to me with bilateral leg pain on a scale of 1 to 10. He says the pain is a 6. It is a shooting, pulsating pain that increases within walking. His distance is usually 100 meters before it starts hurting. The pain also increases during cold weather, and he does experience cramping. He also is known to be a smoker. He smokes a pack a day for the past 20 years, and he's a social drinker. My main differential diagnosis would be vascular lower limb claudication, but I would also have a differential diagnosis of DVT, and I would also exclude spinal canal stenosis because he has no pain when going up. The pain is not relieved when going up a hill.
Okay. Does he have any neurological symptoms? He doesn't.
No, he doesn't.
Okay. How would you differentiate between spinal and vascular claudication then, since you brought it up?
Well, if he leans forward or if he's going up a hill, the pain would probably be he would be relieved.
I mean, in general, how would you differentiate between a peripheral vascular disease and a spinal claudication? So we're looking at skin changes.
The skin changes,
vascular disease, yeah, the temperature.
He'd have ulcers with lower limb claudication, but with spinal claudication there would be no ulcers.
Yeah, or skin changes in general, doesn't have to be ulcers. Temperature, walking uphill. So spinal is relieved by walking uphill. Spinal claudication will have neurological symptoms or weakness, or have back pain, and so on. So what investigations are you going to do to this patient?
I'd like to do a CT angio, but before that I would do a full peripheral vascular examination, maybe start by a Doppler and a duplex, and then I would do a CT angio if intervention was needed.
Okay.
As well as
Yeah. So first we're going to start with an examination, full vascular, cardiovascular, and neurological examination, and of course assessment of his gait, and then arterial duplex, CT angio, or an MRI angio. Treatment, of course, if the patient is diabetic, then we need to optimize his blood sugar, his cholesterol, his blood pressure, so on, antiplatelet agents, anti-lipemic agents, and in the end, surgical treatment, which can be a stent or a bypass, or in severe cases, amputation. Good,
okay.
very good. Well done.
Thank you.
Have you booked your exam?
I was supposed to
Not
be
yet.
doing the November examination, but I'm not really sure how things are going.
Not sure. Okay, that's fine. Yeah, you have plenty of time. Well, everyone has plenty of time now. I'm sure you'll be fine.
Thank
Great.
you.
Bladder cancer. Who wants to do this station? Oh, we have a new participant. Perfect. Dr. Muhammad Awad.
Yes.
Hi. Do you want to do this station with me?
Yes.
Perfect. All right. So again, we're going to do our normal history taking scheme. Okay. And
Okay.
we're going to exclude our differential diagnosis. So exclude cancer is always constitutional symptoms that will be in question number 2. Other problems like calculi, question number 2. BPH, question number 2. Family history, for example, for polycystic kidney disease, that's going to be in question number 8. And family history, bleeding disorders, that's in past medical history. Blood thinners, that's in medication. Instrumentation, and previous surgeries. Okay.
Okay.
History of trauma, question number 2. And of course, don't forget to ask about his job, because I think this patient works in a dye factory. Ask about certain medications that might cause discoloration of his urine. Okay. And ask about back pain as well. Okay.
Okay.
But it's a
Okay.
normal history. So
Okay. Okay.
I'm ready when you are.
Okay. Can you give me the stem of the station?
The stem is the patient. I think he's 55, and he has blood in his urine, and he's concerned, and you're asked to take history from him.
Okay. I'm ready.
Yeah,
Yeah.
go ahead.
Hello. I'm Dr. Muhammad,
All right.
one of the surgical doctor today. May I confirm your name and age, please?
My name is John, and I'm 55 years old.
Nice to meet you today, Mr. John. How can I help you today, Mr. John?
Oh, I'm really worried, doctor, because today when I went to the loo, I found some blood in my urine, and I'm really worried.
Okay, Mr. John, I'm sorry to hear this. Would you mind if I will ask you a couple of questions to rule out your problem?
Yeah, of course.
Okay, Mr. John, can you tell me first when actually this started?
It's just today, the first time this has happened to me.
Okay, Mr. John, is it started suddenly or of gradual onset?
Well, I'm not sure. I just went to the loo and I noticed that my urine is red.
Okay, just it is started. You don't know it is uh, since starting it is constant or you are somewhat improving or you don't know.
Well, it's just happened the once today, so I don't know if it's getting worse or not.
Okay. Mr. John, can you tell me a little bit about this condition?
Sorry.
Is this blood uh, is this blood comes when you start your stream or it is in the midstream or it is terminal?
Oh, it is midstream, I think.
Okay, it is midstream. Okay, Mr. John, do you think, I mean, today, do you think there is anything that relieve this problem for you or you get better by it?
Well, like I said, doctor, it's just happened the once.
Yes.
So I don't know what makes it better or worse.
Okay. Okay. Mr. John, do you experience any pain associated with this?
No, there was no pain.
There is no pain. Okay. Do you notice any unintentional weight loss recently, Mr. John?
Yeah, I think I've lost weight recently. My wife has been telling me that I've been losing weight for the past couple of months now.
Uh, can you tell me a little bit about this weight loss? Do you think how much you lost?
Well, no, I haven't weighed myself. It's just my wife
No.
tells me that I've been losing weight.
Okay. Mr. John, do you experience any change in your appetite recently?
Yeah, I don't think I'm eating as much. Maybe, yeah, I think I'm losing my appetite.
Okay. Mr. John, do you experience any history of fever recently, or to
Well, I haven't measured my temperature, but I don't think I have any fever. I've been feeling well, apart from maybe under the weather, but no fever or temperature or sickness.
okay? Do you experience any tummy pain, Mr. John,
No
today?
tummy pain. No.
No, no. Yeah, okay. Do you have, Mr. John, an urge to pass urine today? I mean,
No, no.
no. Okay. Do you think that you have any increase in the frequency of urination?
No. You mean recently? No, I haven't. I
Yes.
haven't noticed that. No.
Yes. Okay, Mr. John, do you have bleeding from other offices of your body?
No.
No. Okay. Do you take any blood thinner, Mr. John?
No, I don't.
Okay. Is there is any history of trauma to your tummy or your genital area, Mr. John?
No.
Okay. Mr. John, do you think that you have dribbling of urine?
No, I haven't noticed that recently.
Okay. And what about your stream? Is it weak or as normal?
Recently, it's been normal.
Uh, okay. Do you have any nocturia, Mr. John?
What do you mean?
I
I don't
mean,
understand.
night urination.
Uh, well, no, just a
Okay.
normal.
Okay. You have any back pain, Mr. John?
I don't have any back pain, no.
Okay, Mr. John, I will continue ask you some couple of questions, if you don't
Okay.
mind.
Mm-hmm.
Do you have any medical condition, Mr. John?
Just high blood pressure.
Just high blood pressure. Do you take any medication for this?
Yeah, I take amlodipine.
You take amlodipine. How you take this drug? I mean, how many times and what is it?
Okay. It's now 6 minutes, but we'll continue the station.
Okay.
I take amlodipine once a day in the morning.
Oh, any other
Does it matter?
any other medication for any other medication, Mr. John?
No, no.
Okay. Do you have any surgery done for you before?
I haven't had any surgery recently or ever.
Okay, Mr. John, what do you do for a living, please?
I work in a factory. It's a
Yes,
dye
which
factory.
it's a diver. Okay.
Yeah.
Mr. John, sorry, is there is anyone, any member of your family have the same problem before?
Not that I'm aware of.
Okay. Mr. John, is there is, can you tell me about your health recently, apart from this?
Well, like I said, I haven't been sick. I've been feeling under the weather. I've been losing weight, but no fever or anything.
Okay, Mr. John, I will ask you about your concern. Can you tell me what is your concern about this condition?
Well, my concern is I have blood in my urine. That's my main concern. And I'm worried. I don't know what it is.
Okay, Mr. John, don't worry. You are in a good hand. I will do my best to rule out your problem.
Hmm.
Thank you very much. I will discuss this point with my consultant. I will come back to you.
Okay, thank you.
Thank you very much, Mr. John.
All right. So overall, well, but I would say we need a bit more practice. First of all, this is not pain, so we cannot do Socrates here. So if we go here, this is not pain. So we can't do that really, okay? It's more like a recurrent symptom, even if it's one time. But if the patient gives you a symptom that you don't know what to do, if it's not pain, then you have to elaborate further. So he said he noticed blood. So we can elaborate further on that blood. So we can say, was the color of the blood, was it red or dark? Was there any blood clots? When did he notice the blood? Was it midstream or at the end? All right, for example. Was there any pain associated with that? Okay, and that's really quick. I think you spent too much time elaborating on a simple complaint, and I think you wasted a bit of time there. So in my opinion, it would have been easier to just move on and ask, has this happened to you before? Is it the first time? Oh, yes, it's the first time. All right, so ask about recent health. How has your health been recently? Have you lost any weight? Do you have any shortness of breath? Do you feel more tired than usual? And then associating symptoms, which we are going to ask about BPH. We're going to ask about everything else to exclude our differential diagnosis. So if I go down here on question number 2, we've already asked about pain. So you asked about fever. You asked about BPH symptoms. Do you go to the loo more often? Do you feel that you have to rush to the loo? Do you feel that you've been having poor stream lately? Do you notice any dripping after you finish? Or do you notice any staining in your underwear after you go to the loo? Okay. And that's question number 2. Do you have any back pain? No. And then you move on to question number 3, okay, which is past medical problems. He has hypertension or high blood pressure, and he takes some Lodipine. You have very limited time. Doesn't matter if he takes some Lodipine once or 10 times a day. In my opinion, I don't think it's relevant. Okay, this is just something that's wasting your time. I said that intentionally so I could waste your time. I said I have high blood pressure and I take amlodipine, that's fine. Instead, if you want to know, you can ask him, is your blood pressure well controlled? And he will say, well, yes, I haven't had any problems since taking amlodipine. And then you can move on, okay? I have high blood pressure. Is it well controlled with medication? Yes, it is. I don't have to ask, does he take losartan and amlodipine? What else does he take for high blood pressure? What was his, you're just asking non-relevant questions because he's not complaining of a cardiovascular issue. He's complaining of some blood in his urine. Okay, so we need to, we need to exclude the important stuff and just not pay attention to the irrelevant stuff. And then regular medications. What's most important here is blood thinners. Do you take any blood thinners? No, move on. Any allergies? Doesn't matter, but we're just going to ask it because it's part of history. He has allergy to penicillin or anything, it doesn't matter. Okay, no. Were you admitted to the hospital before and any instrumentation? That's important because he has blood. Maybe he had a catheter recently, okay? And has anyone in your family ever been diagnosed with a medical condition? Sorry. You can follow up with a closed question of cancer. Has anyone in your family ever been diagnosed with cancer? You can or you can't, it's up to you really. You forgot to ask about smoking, I think, which is important because it's one of the risk factors, okay?
Yes.
And you could ask about alcohol and diet. So I don't think you've asked about personal history at all. So that's important. Overall, you've done really well, but I think you just need to follow this structure so you don't forget anything. So if you were following this structure, after family history comes personal history, okay? And in that personal history, you can ask about lifestyle, travel, alcohol, smoking, and so on. And then social history, it's good that you asked me about social, so you asked about work, okay? Sorry, you've asked about work, so that's really good because that's one of the important risk factors. But you did forget personal, and I think you were running out of time. But just for a first try, that's really good. We still have a couple of months to practice. So set a timer whenever you're practicing, and then you have a checklist with you. And then you can make sure that you go through everything in 6 minutes.
Okay.
Okay, very good,
Yes.
very good. Do you think what do you think you forgot to do, or
Yes.
how do you think it
Just
went?
really, this is my
Yeah,
first presentation. Yeah.
it's
Yeah.
really good.
With practice, it will improve.
Everyone with practice, I'm sure they will improve. And for a
Oh,
first time, I think you've done really well because you've said almost everything. Time management is hard at the beginning. It only comes with practice. Okay, so don't worry about it really right now. Just focus on getting everything, and then time management will come with practice. Okay, so very good. It's just more practice.
okay.
Okay, would you like to present the case?
Yes.
Yeah, sure, go ahead.
Okay. I'm presenting Mr. John, a man of 55 years old, presented with bilious hematuria.
Yeah,
Just happened today. And it is associated recently with weight loss and also loss of appetite. Also, patient work in a dye factory. Uh, he concerned about this complaint. Patient also being diabetic and his sorry, being hypertensive, and his hypertension is controlled. So my main differential diagnosis could be bladder cancer or renal cell carcinoma. Also, I have to consider renal stone. I have to consider urinary tract infection, trauma, and bleeding tendency.
Perfect, perfect. That's really good. That's a really good presentation, actually. And I think you'll get a full mark in presentation. So like I said, practice the presentation beforehand, but if you're going to memorize it, you have to pay attention to what the patient actually says in the station, because he might give you some slightly different information, which you have to incorporate into your presentation. Okay? So like you said, it's painless hematuria. He works in a dye factory. He's a smoker. He's had weight loss. There's no trauma, no urinary problems in terms of stream. There's no problem with his urine stream. So most likely it's cancer, isn't it? Yeah. And the age fits as well. He's an old male who smokes and works in a factory. So you said the differential diagnosis, and then the examiner will ask you about types of bladder cancer. Okay, do you know what they are? There's some part
Yes.
A. Yeah.
Yes. Yes. Squamous cell carcinoma and transitional cell carcinoma and adenocarcinoma also.
Yeah.
I think there is for some.
Yeah. Small cell.
Yes.
And then investigations. What will you do for this patient?
Yes. For this patient, after I will do full clinical examination, I will do urine diagnostic to confirm hematuria and to rule out infection, and also I will send sample for cytology.
Yeah, of
Then
course.
then I will take blood for blood count, urea electrolyte, clotting tendency, as well as prostate specific antigen.
Yeah.
Then I will go to do cystoscopy with biopsy. Also, I will do ultrasound, transrectal ultrasound, and also I want to do CT abdomen for
Yeah.
this.
I think the most important thing is cystoscopy and biopsy, but of course, you can't do that without doing simple stuff like a urine dipstick and some blood tests. Okay, so blood tests you do straight away. Urine dipstick, you ask one of the nurses to do and send a sample. So that's simple stuff, bedside investigations, really, okay, that you can do. And then for diagnosis, of course, you have to do a biopsy or cystoscopy and biopsy. The treatment, of course, it depends on the stage and the grade of the tumor. So transurethral resection of the bladder tumor, we can do that. And sometimes when they're doing that, they can just inject some chemotherapy in there as well. And then he can have cystoscopy as follow-ups, or we can just remove the whole thing, radical cystectomy. Non-surgical, you can do chemo and plus minus radiotherapy. And of course, it depends. I don't think in the exam they will go into much detail. They just want to know that you know what the options for treatment are and you know what's going on. Okay. Why does this patient have trouble passing urine? Well, I didn't actually, but if he did, then it might be because of clot formation from the bleeding, which caused some retention, or it might be obstruction from the cancer itself. Does that make sense?
Okay.
Yeah. Really good, Dr. Mohammed, really good. Our last station today, I think that's, we'll just do our last station, which is the BPH. Well done, Dr. Mohammed, thank you. Does anyone want to do this station? Sorry, Doctor. Let's do Dr. Abu Bakr.
Hello.
Hello, Dr. Abu Bakr. How are you?
Hi. Fine. How are you?
Yeah, not bad. Are you ready to do this station?
Yeah.
So this is not pain. So we're not going to do Socrates. Okay.
Okay.
So we're not going to do that. The patient has problem passing urine. So we're just going to elaborate further on that. And it's not going to take much really to elaborate. Then we can move on to to the 8 questions. So if he had previous problems passing urine, and then you can ask the specific questions about BPH, so about hesitancy and frequency and so on. And then you can carry on doing your normal scheme. Okay?
Okay.
Perfect. I'm ready when you are.
Yeah, I'm ready. Hi, I'm Dr. Abubakar, one surgical doctor. Can you confirm your name and age?
Oh, my name is John. I'm 61 years old.
Can I help you today?
Oh, I've been having problems going to the loo recently.
Can you give me more details about that?
Oh, yes, doctor. Well, when I go to the loo, well, first of all, I've been going to the loo more often. Okay, so I go to the loo almost 6 or 7 times during the night, and I feel that my stream is a bit weak. So I don't know
Sorry,
what's going on there.
I'm sorry to hear you, but I will ask you some questions about that.
Yeah.
Nice. Yeah. Can you give me what time that started for you? That one.
Well, I think it started over the past few months, but gradually I think it's getting worse. My stream is getting weaker and weaker, I think.
Do you have a history of same condition before that?
Well, no, it's just started a few months ago. I had never had problems with my urine before.
Okay. Do you have urgency, distancy?
Sorry, I don't understand. What's
Yeah,
urgency or?
yeah. If you have you you are hurry to pass urine quickly to bathroom, or you cannot control your.
Oh, yeah, yeah. Sometimes I do feel that I have to rush to the loo. Yeah.
Mhm. Okay. Do you have any pain associated with this condition?
There's no pain, no.
No bleeding.
No, I haven't noticed any bleeding, no.
Okay. Okay. Do you have back pain,
I do not have any back pain.
abdominal pain?
Sorry, what's that? I
Do you
don't
have abdominal?
understand.
Do you have tummy pain?
I don't have any tummy pain, no.
No numbness, lower limb numbness.
No, no tingling or numbness.
Okay. Do you have allergy?
Allergies. I don't have any allergies, no.
Okay. Okay. Do you have any medical condition?
I haven't been diagnosed with any medical conditions, no.
Are you able to hold your urine?
Well, to be honest, I think I'm having trouble with that recently. Over the past couple of weeks, I did notice a bit of staining in my underwear.
Do you have feeling of yeah, you cannot empty your bladder or pass all urine completely?
Yeah, I think so. I think because of the poor stream, and that's why I'm going to the loo more often because I don't think the bladder is completely empty. I think
Okay.
that might be a problem, yeah.
Okay. Do you have poop pain, generalized poop pain, or specific kidney pain, the bone?
No, I don't have any bone pain.
Do you have any problem of erection?
I don't know. I don't think I do, doctor.
Okay. Do you use any medication, drug medication, or something like this?
I just take some nasal sprays for some asthma, but other than that, it's fine.
Okay. You have history of trauma before?
No.
Okay. Okay, you are smoking. Are you smoking?
I do not smoke, no.
Okay, using alcohol. Are you taking alcohol?
Yes, I do drink, just socially though.
Okay. You have history of admission before?
You mean to the hospital?
Yes.
No, no, I haven't been admitted to the hospital before.
Do you have any history of surgery?
I haven't had any surgeries in the past, no.
Okay. About your family, do you have any problem in your family? Father, brother, sister, you have any family history?
No, my family, well, they're fine. I don't know if they have any problems, no.
Okay. What about your physical activity? You do exercise, you take healthy food or
Well,
what?
I think I'm average. I try to exercise once a week, but I don't go
Okay.
to the gym or anything.
Okay. Your can I ask you about your job?
Oh, well, I'm retired now. I'm 61. But I
Oh,
used to be a real estate agent.
okay. Do you have history of travel outside?
I haven't traveled recently, no.
Okay. Okay, thank you, Mr. John. I will ask my consultant to take some information about your problem, and I will come to you back again.
Hmm.
Thank you.
Okay, thank you very much. Okay, Dr. Robobot. What do you think? How do you think it went?
This
Do you
is
think you
first time.
forgot anything? Yeah, yeah.
Yeah, yeah,
And
yeah. I
what do you
think I
think?
think I I think I forget, but
Well,
because
no, I think
I
you've
put
done
myself in
well.
exam. Yeah,
Yeah,
I put
I
myself in an exam in under tension also to do that.
I think you've done well, but I would say just a couple of things. But overall, you've done really well. But just a couple of things. First of all, in history and communication, you need to use layman's terms. Layman's terms,
Yeah, yeah.
always, always, always. Do not say abdomen. Don't say hesitancy. Don't say nocturia. You will lose points. Okay?
Yes.
There is a lay examiner in the station. Okay, so there's an examiner. There is the lay examiner.
Mhm,
Okay, and there is the actor or the patient.
mhm.
And if you don't use layman's terms, and this is for everyone, by the way, not just for you. If you don't use layman's terms, if you don't develop rapport, if you don't show good communication skills, you will lose points. Okay? But overall, I think you've done really well. I think if you follow this structure a bit more, I know it's a bit new for you guys, but if you followed it, then you won't forget stuff. So first, after we elaborated, we want to ask specific questions. In question number 2 about BP8, right?
Mhm.
And I think you almost forgot some of these. You asked a few of them, and then you moved on to past medical history, and then you returned to ask about a few others, okay? Just remember that you try to ask all of these questions, okay? And here I've written the way how to ask them. Of course, you can ask them in your own way, but this is an example. Urgency, do you have to rush to the loo? Incontinence, are you able to hold your urine? Okay. Hesitancy, when you go to the loo, do you have to wait until your urine starts to go? Frequency, do you go to the loo more often? And I did say that, so you don't have to ask it because I told you I've been going to the loo more often, right? Whole stream, I told you I have poor stream, so you don't have to ask it. But you didn't ask about dribbling. There's a bit of urine drop and stain your underwear soon after you go to the loo or soon after you finish. Okay? And then excluding other stuff like neurological problems, maybe it's called Aquina, right? The problem has
Yes.
problems with his bowel. So we have to exclude that, right? You have to exclude neurological symptoms, weakness in the legs, and so on. Drug history is always important. I think here is specific because the patient takes a beta 2 agonist or takes an alpha agonist, which might interfere with your treatment options afterwards. Okay. Yeah, someone mentioned IPSS questionnaire. Yeah, you can have a look at that. So that's about BPH. I've added it. I don't think it's in your Google Drive. I did add it to the previous Google Drive for the previous course, but I can add it to your Google Drive this time as well. And it's a questionnaire for BPH or prostate problems. Discussion, can you present your case?
Yeah, I saw today Mr. John is 55-year-old male presenting with
Mm-hmm.
difficulty in initiation of urine on a slow stream and increase in frequency. He
Yeah.
does not have any dysuria, hematuria, or
Mm-hmm.
pump pain, or weight loss, or loss of
Mm-hmm.
appetite.
Mm-hmm.
Okay, or any neurological complaint. Patient who has medication on alpha beta blocker, alpha blocker, and nasal spray containing phenyldipine and alpha agonist.
Mm-hmm.
Uh, just that one.
Okay. What's your main
Okay.
differential then?
PPH, benign prostatic hyperplasia.
Yeah. So
Okay.
old patient, problem with urine stream, yeah. Nocturia, poor stream, increased frequency. There is no dysuria, no hematuria, no bone pain, no constitutional symptoms, no neurological symptoms. Okay, so most likely it is BPH. Okay, it's not painful. There is no blood. There is no other signs. He's 60 something. Okay, and he has BPH symptoms, so it's most likely BPH. Okay, but you also have to exclude other problems, okay, such as any obstructive pathology or malignancy or calculi. You have to exclude overactive bladder or prostate cancer. Okay, so what will you do for this patient? What will you do for this patient?
First, I will take full, after take full history, I will do full clinical examination, okay,
Mm-hmm.
including diarrhea, and also I will do your input and output chart,
Yeah.
okay. I will do also process scoring system,
Mm-hmm.
IPSS,
Yeah.
okay. I will take the patient in bedside blood, CBC, tumor marker, PSA, and also urine
Yeah.
electrolyte.
Yeah.
And I will take
Yeah.
also urine analysis for infection. I will send culture and CCTV also if there is cancer positive. I will do for him also imaging ultrasound, even CT purpose I will do after ultrasound if there
Okay.
is some.
Well, yeah. Well, I'm not sure about well, CT maybe if you find something and you want to stage, yeah, of course. But for here, we're going to start with examination,
PBH, yes,
including digital rectal examination, very important.
PR,
And
PR,
then
yes.
the charts, you do the bloods, full blood count, prostate specific antigen, normal UNEs, urine analysis, okay. And then imaging, you can do an ultrasound scan, which can be abdominal or transrectal. In terms of treatment for BPH, there are two main medical treatments. You have tamsulosin and finasteride. Okay, one of them is an 1-alpha blocker, and the other is 5-alpha reductase inhibitor. And you'll be asked actually about their mechanism of action. And if that doesn't work, you can always do a transurethral resection of the prostate. Okay. When you say the medical, I actually had this taken in my exam. When you talk about the medical treatment, the examiner will ask you, how do these medications work? So one of them is an alpha blocker, which works by relaxing the bladder and prostate muscles. And the other is finasteride, which is 5-alpha reductase inhibitor, which causes the prostate to shrink and prevents growth, okay? Which that takes a bit of time to work, while I would say tamsulosin works more quickly, okay? If the patient is taking phenylephrine, will that affect your management? And what about salbutamol? So the patient tells you that he's taking phenylephrine, okay, and it will affect your management because it will
Agonist.
antagonize the effect of tamsulosin, because this is an alpha agonist while tamsulosin is an alpha blocker, okay?
Yes.
So if the patient is taking phenylephrine, then it will antagonize it. But if the patient is taking salbutamol, it will not affect our management because this is a selective beta-2 agonist and it won't affect our management, okay? So these are two questions. If the patient takes phenylephrine, then yes, it will affect. If the patient takes salbutamol, it will not affect, okay? And then you have other causes of increased PSA, you have age, BPH, prostatitis, urinary tract infection, even sexual activity and trauma will increase the PSA, okay? The examiner might ask you, what if the PSA is increased? And in that case, you need to do a free PSA instead of a total PSA. And free PSA is the amount of PSA that's floating freely. It's not bound to a protein, okay? And that's it really. And here I've added just some info about free PSA, okay? So if you have a lower value, that means there's a greater likelihood that an elevated PSA represents cancer, which you can read at home. And that's it. Very well. Well done. I think that's it for today. Does anyone have any questions? Thank you, Dr. Abu Bakr.
Thank you.
It was really good. We all just need a bit of practice. I know it's really hard to do history in 6 minutes, but unfortunately for the exam, we have to do it in 6 minutes. Okay, and it will be much, much, much easier when you practice. Okay. And like I said in the beginning, history and communication are one of the easier stations that you will have in your exam. Okay. Any questions? Is everyone happy? I hope it was useful. Don't forget to practice. And if you do remember a question, then just add it to post it to the Telegram group. Okay. Thank you.